I just have to say that part of this presentation have been given invited talk at CIRSE 2023, a year ago, in Copenhagen, and clearly most of it is about the specific points in radiation protection. So this is something from previous, from this presentation in Copenhagen. So we talk about the emerging countries that, in our opinion, this is it was a paper by Dr. Sharma. It has a benefit specific for most of the African countries, because if you incorporate these interventional radiology techniques in the clinical practice, clearly it's a big challenge, and the benefits of these advances have not yet penetrated in medicine. So if you use intelligently interventional radiology, we can reduce the cost of disease management and hospital stay and influence the health economics. So far, unfortunately, IRs failed to establish themselves as a clinical specialty. Just a minute. Sorry. Training in Western hospitals is mostly focused on spreading skills in disease-specific procedures, and it's relevant to their native regions. Clearly, in Africa, in many countries, it could be different, the prevalence of diseases and their severity. I will try to address that. So without elevation like CME, that is the next step. It should be implemented, in my opinion, in the training of residents in any country. So initially, we should do basic non-vascular procedures, then moving to the relevant vascular interventions, again, relevant to the same country, to the same area or region. So, and again, having Dr. Lage and others as the mentors, you can always refer to them and having the consultation, sharing the images, etc., and make sure that you will give the most appropriate and the effective treatment to your patients. International Atomic Energy Association prepared and will soon publish a document on relevance of interventional radiology in the emerging countries, and the name of the document is Needs of IR in Imaging World Countries. Regarding the assessment of the IR services and the access unfortunately is very limited or absent. I know that in these days it's changing, it is very important, and I hope that the Happy New Year I wish to all of us will bring more and more our colleagues to this subspecialty of radiology. Very limited number of publications coming from Africa. I'm not talking in this case about Egypt or South Africa, because they have it high level. I'm talking about the other countries, and the numbers of variety and of imaging and interventions is clearly rising, but numbers of the certified, and this is a very important point, we have certified interventional radiologists is lacking, and the radiation protection equipment also is a problem. It's expensive, and the maintenance is very expensive. Again, radiation safety training, we just start now, clearly is insufficient. IAEA training courses attempted to address this gap, but there's also challenging in the most of us are not really, we know if it's available and how effective it could be. One of the most important points that we can address here is the planning of the procedure and knowing the radiation exposure. So we're very much aware of possible complications and do the utmost to prevent it. But the most important contributor of radiation exposure in interventional radiology is fluoroscopy. Today also is a CT or CT fluoroscopy. I will not address it today, and if you would like it, I have a lot of experience with that, and I can share my and clearly the literature about this very important topic. So time-efficient performance of procedure ultimately will lead to shorter fluoro time, less DSA, digital subtraction angiography runs, and reduce exposure dose. Cone beam CT is a game changer and allows to perform procedure based on very few acquisitions. Cone beam CT is part of the modern angio equipment. It's not a CT, it's different. Procedure planning should integrate those management measures. Goal is an efficient and optimal use of radiation. It's very important, not an irrational fear or negligence. Unfortunately, most of our colleagues are one of these or both. Okay. What about another paper about the local regional challenges for interventional radiology practice in Middle East and North Africa? Some programs focus primarily on the embolization, less exposure to aortic and peripheral interventions, and necessitating collaboration among institutes across the country. One important point, recruiting the women to vascular intervention radiology is a global challenge, very few unfortunately, and this is not really a good reason for that. I will address it. Despite the work environment and social challenges, women are increasingly joining IR due to increased demand for women. Health-related interventions, I will address that on the uterine fibroids, due to the conservative nature of community and region, and this is something that I cannot change, but we can do our best just making sure that you know about this. We have two ways of radiation protection. One of them is the passive. Passive protection is something that you have with your angiography system, okay? And passive methods. These methods are operator independent, and any possible active consented protection is the key. Passive methods are of no use if they are not utilized in our daily practice. Active protection. Active protection, we are obliged to protect ourselves and the patients. Any available passive means, the equipment, dose reduction methods, I will talk about it, and adjust our behavior to the hostile settings of the angiography system. Active methods allow proper performance of the interventional procedures with the lowest radiation exposure for patients and staff. Again, pre-procedural imaging, CT angiography or MR angiography. I'm not saying that MR is better than CT. Each of them has specific indications, but CT is more available, and they should be routinely used prior to almost any endovascular procedure. CT angiography became a routine, must to have imaging for diagnosis, localization of bleeding, for example, in setup of trauma or GI bleeding, and not me, but there's specific areas, I don't know, in each country, there's endless stab wounds, and this, when available, instead of chopping patient, very basic angiography with the embolization is the most effective method today. The imaging allows proper planning of the access, which is very important. Choice of catheters for quick access, and safe and accurate performance of intervention itself. So this should be routinely used. Sorry, okay. Now we talk about the modality-based patient radiation dose. In most of the interventional CRs, we have KERMA area product or dose area product. And when you see your X-ray tube, there is a system on the top of it, and it gives us the evaluation of the gray per centimeter. Talk about the radiation that is coming, the primary radiation that is coming from the tube to the patient, and this is called KERMA, the distance, and the distance is very important. We also have to be aware of the cumulative skin dose or air KERMA as the patient enters FND, and we talk about, and this is measured and evaluated in milligrays. I'll show it in a moment. And for rotational acquisitions like PT, like modes that I mentioned, cone beam CT, the same quantities should be used. So we talk about the fluoroscopy and CT, cone beam CT acquisition is the same. When we look at CT, as you know, in CT we use CT dose index, which is different, or DLP, dose length products. So these numbers are different. Okay, this is the tube. This is the image intensifier or image receptor. Today, most of them are flat panels. And this isocenter shows where we evaluate or calculate more exactly the radiation exposure. It will be like isocenter. If it's a child, it will be different clearly, but in the adults, it's about 15 centimeters. And this distance from the tube to the patient table is extremely important when we think about the possible exposure of the patients. And please keep in mind, as much exposure is going to a patient, you have more. One of the important principles is named ALARA principle, which is as low as reasonably achievable. You should have diagnostic, not beautiful images to perform any fluoro-guided procedure within the minimal fluoroscopy time. I don't know if you are familiar with the Gordian knot, if you are good in the history, but Alexander could open this node. Please remember that radiation protection is the Borromean rings. If any of these three Borromean rings is removed, the other two are no longer joined. So we should be knowledgeable and do. Please look at these two images. I can show these magnified images. I don't see real difference between them, but look here. The first one was taken with 100% dose, and this one on the right, 17% dose, and you can see the dump dose area product, 5,500 compared with only 920. So what we need each modern equipment can give you this kind of possibility to use low dose radiation. But one of the important things is, and if you have a car or something, you should know how to drive it and how to use your, make it sure that you are safe. The same applies for your Argent suite. It should be, you don't have to be completely rely on your radiographer. You should rely on this person, but you should know better yourself for each procedure plan what you want. Something which is relevant for most of the countries, at least in Africa. So the usual technique is some people are using two catheters in distal uterine arteries, and we can inject simultaneously. Clearly, it should be low frequency pulse fluoroscopy, and we need pre and post embolization exposures. We should avoid magnifications and oblique fluoroscopy because today most of the patients could be in the childbearing period, like young ladies, and we should make sure that they will be able to get pregnant. So 50% reduction of the estimate observed variant dose could be achieved compared to the routine methods. And I show you here 22 compared to 9.5 centigrade in this case. Mean absorbed skin dose is can be reduced. It's very impressive from 162 to 48. Threshold doses for induction of deterministic radiation injury to the skin is 400 to 500 centigrade. Now, I just have to note here that we know about two possible damages caused by radiation. One of them is stochastic, and another is deterministic. Stochastic injury is like you buy a lottery ticket and you hope to win, or, in most cases we don't, but you can have this something out of that. But we should, stochastic injuries are considered as possible danger, and we should avoid them. Deterministic injuries are like when you know for sure that when you irradiate the patient, or it's like atomic bomb, the damage will be caused absolutely for sure. So we should know the difference between these two. Now we are working on the occupational radiation protection in terrestrial radiology. We have a joint guideline of CIRSE and SIR. I am a part of the group, and it has been approved by executive committees of both societies, and we are working now. It will be 24, 25 on the updates on the guidelines specifically for the staff radiation protection. Some basics. Beth Schuler is one of the team. We work together. She's a medical physicist from the United States. And this table, it is very important to see. You can see the colors showing the radiation coming to the operator. And we should remember that as if you have a big American, patient, should not be American, just saying, then the radiation from that patient will be much higher compared with child. Children are less dangerous for us compared with the adults or compared to the large adults. And you should know that. My slides are not moving. Any reason for that? No, sorry. Oh, please have a look at the feet of this interventional radiologist. You see this? It happened to him because this part was not protected, and X-ray tube, there is a leakage radiation from the tube from the day you buy it, and when it comes older, then the leakage is higher. Therefore, you should make sure that the protection will go down and you will not be exposed there as well. Leather glasses. Leather glasses may provide inadequate protection, and we should seek for some alternative techniques. And the problem with these deterministic subcapsule opacities, and they are 3 times more common than interventional cardiologists than the cardiologists. And it clearly has some other problems. I mean, some other sources like age, smoking, and other confounders. And this is a very important slide showing that, have a look here, it's lead equivalence. We measured it in lead equivalence, okay? Although it should not be a lead, but just look at this lightweight, 0.07 lead equivalent, when the, usually it's 0.75, 0.75. You can see the difference in the weight. And what is important, that these glasses cover more of your face, because the cathode radiation is coming from the patient to us, and you don't keep your head down, you look at the monitor. Therefore, these glasses are good, but the scatter radiation can enter there. This is also effective, but the lightweight are almost as good as the others. Hands. Never keep your hands in the primary beam, and better use pulse, low dose fluoro when you are close to the primary beam, especially when you do renal interventions, prostomies, biliary interventions, drainages. Should be very careful with that. The gloves, they do not protect from primary beam. Please remember that, the leather gloves. Some protection from scatter, and the problem is that it reduces your skill because you don't feel the catheter. So what we do, we cut the end of the leather gloves, and they put other glove, sterile glove on them, and then you can feel your catheter. So in cardiac interventions, on the peripheral interventions, you don't need this at all. And you should always keep your hands out of field of view. This unlucky guy didn't do it, and you can see what is going on when he's doing femoral procedure and doing fluoro with the hand. So please avoid that. Musculoskeletal pain in interventional radiology. This paper from 2020, 9 out of 10 interventional radiologists experience musculoskeletal pain, mainly spine, and most of us, it's attributed to the work-related activities, back, shoulder, neck pains, and the factor that increase risk for that is females, BMI, keep your weight down, and the practice length over 10 years. You can see it here. This increased health risks compared different ages, etc. And you can see the orthopedic illnesses are the champions, so it should be avoided as much as possible. One thing that I can already give you a tip, if any of you has some kyphoscoliosis, knows about it or had some images, should be extra careful, because it definitely, this person will suffer more than the one who has not. What about the protective equipment? If you have it, and if you have it, if it's okay, and if you have it and it's okay, but you don't keep it properly, there's a big problem. So protective goggles, as I already mentioned, curtains and shields, no dedicated radiation safety programs is another problem. I hope that we are beginning with that. And please remember that the radiation safety is not something by itself. It's part of interventional radiology. If you are not doing it properly, you will you harm yourself, harm your patients, and the outcomes of, I can tell clearly that the outcome of the procedure, if you don't take care of this, it won't be as good as it should be otherwise. Those, I'll talk about it later. Those reference levels, each country has to have it, but as far as I know, they are not available in most of the African countries. I'll be very happy to know that I'm wrong. So all of the above reduces safety. What about the IR's role in the management? This is the thing of the postpartum hemorrhage, which is very high mortality, especially in low-income countries. And I know that it's a big problem. So what we know that according to the World Health Organization, international resources are limited, and global network of trained IRs can support this program challenging situations. So if we look at here in the same paper, which was published in the CVAR, the role of the interventional radiology in the management of the postpartum hemorrhage, global network of trained IR can support these programs. And for example, one of our colleagues who is very active in African continent as well, Professor Vincent Vidal and colleagues, they reported this fair EMBO, for example, he had an idea, and which is brilliant. By all means, you can do homemade embolic materials, pieces of surgical sutures, and so put it in with in your syringe with some contrast, and inject it to the patient, because in such cases you need tons of the embolizing materials. And there's an effort by WHO to promote image-guided interventions in these cases. You see this image here. I hope that you know what's wrong with what they do, our colleagues here. And the ceiling suspected screen is not properly used. It should be in front of the interventionist and not behind the back. But you know, it happens to most of us because we have to do something. We just move it back. We should remember, sometimes it should be done, but we should remember that to place it back. This is one of the posters we had at Circe in Lisbon. And I always wondered if the thyroid coverage is appropriate using the thyroid protective collar. And our aim was, as the thyroid is very radiation sensitive, wanted to check if we use it properly, and standard thyroid radiation protection collar might not cover the entire thyroid. And our conclusions were that, unfortunately, I was right, and we done this work here in Tel Aviv Medical Center by the ultrasound people, and initial results of prospective studies show that the thyroid gland is not protected from the scatter in the loose or slightly loose thyroid collar feed. It's completely protected in all cases if it's tight. Problem is, I don't know how good the air conditioning is in your cat labs, but we sweat and we make it loose, and then we lose twice. So we are going to expand this study. Musculoskeletal problems, continuing with that. Overload with negative effect of MSK problems, mostly spine, as I mentioned. Whole body biomechanical overload causes discomfort and fatigue, and the result is reduces ease of the movement, limit joint movements, and changing posture. I'm currently working with my colleague from Denmark. He's originally from India, and we are working together on the paper of the use of yoga methods to reduce this burden to the spine and to the musculoskeletal problems in general. And I believe that we'll publish it quite soon. There will be clear recommendations, and we have a very good audience in India, because yoga is from India, and we are already working with those who practice yoga and those who do not, and we can see the difference with them. And so we should address specifically if there is a pain in the neck or pain in the shoulder. Now, this is another product made by a Swedish company, which is named, the company is Texray, and there's a paper that's coming from Germany. They could clearly show By the way, I have to say that I personally made some studies with my Spanish colleagues from Madrid, Professor Vano and his group, evaluating the phantoms and having very impressive results. But I'm giving here, because the clinical study, it is called this mind piece, and this is the head piece, and then it is reducing very significantly. This is the results, but they could have 74% radiation dose reduction towards head and neck. And we are working now on the new design that will also cover the eyes and the face. And this is very important. It was presented at the meeting in Germany. The future in the vascular robotics, you can see here, Corindus originally was the father of this device is Professor Rafael Biar from Rambam Hospital here in Haifa, but now it's equipment by Siemens, very expensive, but very efficient. You just get the catheter in, and then you can perform entire procedure sitting very safely behind the protective screen in the room. The other very important is the exoskeleton. It becomes very much relevant for the military reasons, and for this is some futuristic movie, and also for the medical stuff as well. And you can see it here, exoskeleton. And this is the kind of robot, and this is the some engineer from Israel. He has a complete paraplegic, and he made this device that he can walk over 40 minutes, and they will go upstairs and downstairs. And I know that there are some similar devices already on the market. Unfortunately, I had many surgeries, and this is one of them. This is my spine. It's nice reconstructions, and I just made it. It's called Hangam High. Initially, it was made by some company, Cook, but they stopped this. And I was the only interventionist at that time in the hospital. So we made it in some workshop, and my protective, all of my, besides the thyroid collar, everything is on the device. So I could practice it 2 weeks after the surgery. Exoskeleton is another company which is named Stemrad, and you can see how it happened, how it can work, and this whole thing is in here. Okay, no weight on you, and there's excellent protection to your eyes as well, completely. Okay, so and this is from clinical from the United States. These guys are practicing using these devices and these exoskeleton devices, which are very effective and very expensive. But this is the future. What about the future? The weight of lead aprons limits our mobility and causes fatigue. In long term, it links to orthopedic issues in most of us. Lightweight, ultra-thin, disposable radiation protection becomes available and will likely become the new normal in the cath labs. Will they really? I'm not sure about that, but this is work. We are moving in this direction. So what is the key? This is a paper we published. It was an invited paper published back to 2018 with my colleagues, Mano and Dr. Seiler from the United States. And we have been careful balancing with the comfort and protection. We have to use any possible means. And if you are busy interventional radiologist, you better choose a good protective apron based on your personal dosimetry data that relates to your radiation skills. Because if you do one procedure a week, it's okay. But if you do 10 a day, you should be very careful. Clearly, how safe is your equipment if you have all you need for protective screens, and etc. If you have a medical physicist, you should consult him, and you should request official results from multi-energy if you buy apron or something, because if you read the small letters, you can find that is not as good as they claim. What are the key points for safe practice? Plan the procedure ahead, obtain training, started with that, minimize your fluoro time and number of spot images, use available shielding, both personal and equipment, use collimation, clearly should prefer off fluoroscopic collimation, which is available in new X-ray equipment, and make sure that you are in the low scatter area, and wear your personal dosimeters, and you should know and understand your doses. Last but not the least, you can have this and decide the IA tutorial for radiation protection interventional radiology. Thank you for your attention. And I don't know if we do have time for questions. If yes, I'll be happy to address them. Thanks. Are you with me?
Thank you so much, Dr. Gabriel, for such a wonderful presentation. So I would like to welcome the floor for any questions or clarifications, if there are any, particularly from fellows.
Maybe it will be more relevant again if we schedule next meeting like this, and if my colleagues have questions, I'll be more than happy. They can refer them to you, and then once I have it, I'll be more than happy to share the state of the art and the experience in this, and we also can give an access to the radiation protection guidelines, CIRS and SIR, which have been published back to 2010 and 12. And as soon as we'll have new guidelines, I believe it will happen in some months. It's under the review of the journals, both journals, SIR and CIRS and CVIR, and clearly JVR and CVIR, to be exact, and clearly you can have an access there, or can share them with you.
Hey, Gabriel, thank you so much for the lecture. And I think for all the fellows, there's like a lot of information. Gabriel, like I told you before, we really haven't incorporated much, if any, radiation protection training so far in Tanzania and Uganda. So this is all still very new. But what I'm hoping for Monabas and all of your other trainees is that you guys really start thinking about this more every day as you do fluoroscopic and CT-guided procedures. Really try to think about it. And then, as you start thinking about it more, then maybe also some questions will come up that, you may want to then ask Gabriel going forward, or Monabas, you can start collecting some questions, and Gabriel can then kind of tailor the next lecture around some of those questions. Gabriel is really an international expert, and any questions that come up, most likely he'll be able to provide some sort of answer for them.
You are very kind, Fabian. What I can tell you that as long as I have no idea which equipment to use, it will be very helpful for me to prepare my next meeting with you. Hopefully, if you mention which company and what kind of equipment you have, then I can tailor the specific methods for all of them, because I'm giving talks to orthopedic surgeons, urologists, and cardiologists, of course, and it will be very important, because whatever is relevant for high-tech, very recent angio equipment could be irrelevant for basic C-arms, etc. So
yeah, we really have a mix, So in Tanzania, for instance, we have the Andrews reader Siemens. It's a Siemens Axis Z from probably the, I don't know, maybe it's like the 2019 model or something. It's like
Oh, it should-
relatively
It's okay.
relatively new. But then we also in Tanzania had a C arm. One of us, is that C arm already repaired or it's still out of commission?
Still out of
It's still out of commission, but at some point we will have a C arm again. But anyways, we had like an older Siemens C arm there, and I think that the hospital's either repairing it or I think actually hospital's getting a new C arm. So we also do work with C arms. And then we have 4 CT scanners in Tanzania. It's all Siemens. I think one is like, I don't know, 128 slice and the other one 64. Is that correct, Monobus?
That's okay. Sounds
one
good.
And then
and one is 128.
128 there. And then in Uganda, we have the fluoroscopy we use there. Alex or Eva, can you guys specify? Because I don't really know what is. One is like an old fluoro unit. You know, it's sort of like a fixed fluoro unit, you know, that you would use for, GIGU procedures, etc., like very high radiation. But then I don't know what exactly the C-arm is. Alex or Eva, can you guys specify? Is it also Siemens? Maybe you guys can just find out what exact model and then you guys can share it with me and then I'll pass it on to Gabriel.
Sure, boss, we will do that.
You know,
Perfect.
some years, Fabian, sorry, some years ago, Professor Marc Sapoval from Paris, you know him, and
Yes.
sorry, and myself, we had a presentation on it was an abstract and yes, how to choose your next angiography room. I can share that. It was like,
Oh yeah, that
Yeah.
would be very interesting because you know in Uganda, for instance, we're in that process right now. We already have space allocated, but we don't have the angio suite in there yet. So I think that would be very interesting for Sam, Alex, and Eva in particular to learn about those considerations.
yeah,
That's great.
Yeah, and I have to find it because it's like back to 10 years ago, but I'll find it in my records and I can share it with you and you will do whatever you find appropriate with that, no problem.
That sounds good. I also wanted to quickly say hi to Dr. Or Professor Charles Sanika, who's on the call. He's from South Africa. He works in Johannesburg, and he's very involved with our training programs in East Africa. I'm not sure if he's able to talk, but would also love to hear about his perspective on radiation protection training in South Africa.
You know, my boss here in Tel Aviv, when I was a resident, he was a very famous professor, Professor Solomon from South Africa. So I'm very much familiar with, and I even can speak South African accent, so no problem. Because
Hey,
of
Charles.
him. Yeah,
Hi everyone, hi Ferdinand. Very interesting lecture and very relevant to our clinical practice in Africa.
Thank you.
And as you said, you also train other specialties. And
Yes.
specific to us in IR, something that we initiated early was to incorporate our general nursing staff and anesthetists. Anesthesiologists were so blasé about radiation protection that they wander all over the place and they have no clue about international about radiation protection. So the need to include other players in the room.
Charles, just a second. You are talking about the anesthesiologist who is giving like anesthesia, or
Correct.
anesthesiologist who is doing the procedure?
Anesthesiologist giving anesthesia while we're doing a TIPS, for example.
Okay, no problem.
Yeah.
He should be sitting behind the protective screen all the
Correct.
time.
But it was not always the case previously.
You know, and also remember they are usually sitting, so they have all the scatter radiation directly to their, you know, intimate areas. So this is something that should be taken into the consideration. But better to have this protective screen it's also useful for the staff. And when you do your DSA run or cone beam CT, if you cannot move out of the room, you better stand behind that. Otherwise, you find yourself in big trouble very, very soon. Okay.
Yeah.
But Charles, what were you saying? Did you guys incorporated them into the training in South Africa?
Yeah, what you then do is you get, I think once a year, in the first quarter, talk to the general theater staff, which includes anesthesiologists, from a physicist or one of the senior radiographers.
That's great.
Yeah.
Yeah, that's an important point. It's like, yeah, also including like nursing staff, psychologists, but also anesthesia. That's a great point.
And I'm thinking of some of the closed spaces in Tanzania. You need your porters, your cleaners, all those guys need to be aware of the dangers of radiation.
Yeah. So look, this talk was just to give you a kind of appetizer, and then we can go down to the specific questions or needs you have, and hopefully I can address them. If I see that I can do it, I have many good colleagues, either physicians. One of them, he is in charge, Professor Don Miller, who is in charge in FDA of the radiation protection, and we work together very closely. And clearly the medical physicists I have already mentioned, so I can address them and give them the most intelligent answer.
So if I may ask, I'm Dr. Baloa from Tanzania.
Yes.
So if I may ask that, is there a possibility of knowing which are the components in curriculum that we can give our anesthesiologists and the nurses? Because currently, as the IRA programs are flourishing, for example, in Tanzania or East Africa, it means that they're going to be so much involved with IRA procedures, and some of them, I think almost all of them have been used only to procedures in the general theaters, or be it other theaters, maybe orthopedic theaters and everything, but IRA, they are not being involved so much. And always they want us to at least brief them on how they can protect themselves from radiation. And as I've mentioned, most of them tend to sit down. And now we are getting into trouble when anesthesiologists want to go out of the room so that to minimize radiation while you are continuing the procedure. And whenever you are in trouble, now you have to call somebody back into the room. Now this is like, how can we make sure that they are in the room and then they are knowledgeable? So is there tailored specific presentations or curriculum that we can ask, for example, the university to incorporate into anesthesia and nursing curriculums so that they are trained on radiation protection?
Okay, there is an interesting paper about the neurointerventions showing how much radiation has the interventionalist and the anesthesiologist, and it appeared in the case similar to what you discussed, because when you do neuro, it's up there in the head, and the most exposed in these cases was the anesthesiologist. Now, clearly, if you have a protective screen, this person could be safely placed there, and there will be, and also clearly use the dosimeter, but in most cases, that person will not be exposed beyond the very, very low radiation dose, but I can address it clearly, no problem, thank you. And the nurses, sorry, about the nurses, they should be well protected, and whenever possible, and if the nurse is on the patient doing something, you should stop fluoroscopy for these 1 or 2 minutes. And as long as this he or she is done and moves back behind the protective screen or to the other room, you can go on. So this is something that it is the active radiation protection. It's our behavior, okay? We call it also kind of radiation protection culture. This very important point. We are trying to disseminate it today because it's like how you or your kids behave, whatever, and our behavior in the angio suite should be based on this culture. And I try to give you just a scent of it. And there is a lot behind that. And clearly, what you mentioned, the training for the nursing staff and radiographers, their training should be a part of the radiologist training, okay? And they can take from that whatever needed. So usually when I'm giving these talks, the radiographers are usually present, and I also give them annually the updates, as well as the orthopedic surgeons, vascular surgeons, cardiologists, and the gastroenterologists with the ERCP, and clearly the urologists as well. You know, it's a huge, but